Hello, I'm Mike Reed. I'm one of the orthopaedic surgeons at Northumbria. We've been performing fast-track surgery since 2008 and we've gained a lot of experience over the last few years. We've made this film to help people understand about joint replacement surgery and how they can help themselves during joint replacement and also what they might expect.
For Pauline Arthur, getting a hip replacement was a life-changing experience. As a nurse at Hexham General Hospital, she works on the unit carrying out the operations, so knew the benefits.
It began about 10-15 years ago. I had a little stumble and a little ache and pain, and you sort of adjust to moving through your life with bits of pain, but it progressively over 10 years got worse and worse. My daughters used to ride ponies. I used to follow them around with my dogs. I stopped doing that. I'd stand at the gate and watch or wait for them to come back. So all of the fun things just went because you couldn't do them. It would make me sore and then I couldn't work, or it made me miserable, so I stopped doing them. My quality of life was deteriorating to the point where I probably wouldn't have been working in 6 months. It was getting so painful. I was living on painkillers, really, which is not good for you. I was only 50 and I felt like a 90-year-old.
So Pauline decided on a fast-track hip replacement operation at Hexham, one of 3 hospitals in Northumbria which offers this service.
What I want to do is tell you about the fast-track joint replacement system, which some of you may have heard of. I think probably when we started we may have been amongst the first in England. I think there's certainly increasing interest now and there's quite a lot of units interested, and also, I mean, we've had several approaches from other hospitals to come and see our technique as well. So it's becoming increasingly popular, but I would still say represents only a minority of units using the technique at the moment.
And then pop them onto here. And then just tuck your leg in underneath. You feel all right?
Yep.
You feel well supported?
Well supported.
Okay.
Since it developed the service in 2008, the team has operated on patients aged from their mid-30s to early 90s, though the majority are around 70 to 75 years old.
And then operated leg out and hands down. Well done. Very good.
The Northumbria Healthcare NHS Foundation Trust performs around 1,000 fast-track hip replacement operations a year at Hexham, North Tyneside and Wansbeck hospitals. Patients can usually leave hospital within 2 days of their operation.
We seem to be very pleased with the outcome so far. Patients are certainly very happy with it and they're getting away much quicker than they were, mainly because it just seems to be less of an insult to the patient to have the operation. It's less of a big deal. It's more like, the Scandinavians say it's like getting a tyre changed or a brake part changed. So it's less of a procedure.
When you attend clinic and see your consultant and it's decided that you need a joint replacement, whether that be knee or hip, you'll then be invited to attend an education class, and this occurs on all sites across the trust. There you'll meet members of the team, physio, occupational therapist and nurse specialist, and they will each teach you vital information regarding your surgery. Our aim is to try and alleviate any anxieties so that when you're admitted, you're fully aware of what will happen to you and with you during those few days. All hip and knee replacement patients will be taught a wide range of exercises, and these will be demonstrated to you at the education group. You'll be given an appropriate sequence to increase the range of movement at your new joint, and then strengthening and functional exercises. Slowly lower. Excellent. Well done. From your hip. If you're having a hip replacement, it's important that we also teach you some precautions to follow for a minimum of 6 weeks after surgery. This is to allow your new joint to settle. We'll show you certain movements to avoid, and we'll also show you some strengthening exercises.
If you have a hip replacement, you must take care to avoid certain movements in the first 6 weeks in order to prevent the hip dislocating. Do not cross your legs in sitting, standing or lying. Do not bend more than 90 degrees at your hip. For example, do not reach down to put shoes on. Do not put your leg on a high stool. When sitting, make sure your knee is level with or lower than your hip. Do not sit in low chairs. When sitting, Do not twist round to reach for things. When walking, you can turn round to either side, provided that you pick your feet up and do not twist your hip. In the early stages of recovery, do not roll onto or lie on your unoperated hip. In the early stages of recovery, it is not advised to lie on either side. Following this guidance will minimize the risk of dislocation and allow your hip to heal and strengthen.
The whole pathway is shared with hip and knee replacements, and we used a lot of information from around the world on improving the pathway. And that particularly was focused on hip replacement and on knee replacement. And because there's so many shared aspects to it, you know, they've got the shared need for pre-op education, and then the anaesthesia is very similar, and the rehab is broadly similar. We opted to bring it together so that we could get quite a robust system.
We care very much about the person's well-being in general, so a healthy diet, reducing weight, stopping smoking if patients smoke, having dental treatment before they come in for their surgery, reducing alcohol intake, having a well-balanced nutritional diet which assists wound healing. All these things actually make patients more healthy, and then hopefully their recovery will be speedier.
Both hip and knee patients are screened for anemia because that can lead to complications after surgery and may require blood transfusion or longer hospital stays. If blood count is low, patients can be offered iron tablets or an iron drip, as well as being given additional information.
The patient receives an appointment to come to the pre-operative clinic where they are seen by the pre-operative nurses. They go through a whole range of medical tests. They take blood, they do urine tests, and they check on chest function and heart function, and you name it, they do it. That is so that everyone is completely sure that they are safe to go through the operation. I would then spend about half an hour with them talking through firstly their current function and how they are managing with the difficulties they have with either their hip or their knee, the likely outcome of the operation, so their function immediately post-operatively, the fact that they're going to be using crutches or sticks, that they're going to be sore, they're going to be a bit stiff, and what to expect in terms of function from then. I then talk with them about how we're going to enable them to function within their home circumstances during that recovery time. Now, with the hip operation, there are certain precautions that the surgeons advise for the patient to observe just for 6 weeks. And so we work through the practical aspects of that, and you will see how that happens. And then you have a walk-in shower. Does it have a small lip or not?
If the patient has any problems that we discover during the pre-assessment, it could be a heart murmur that's never been diagnosed. The operation would not necessarily be postponed, but in between having the pre-assessment and coming for the surgery, they would maybe have an echocardiogram that I would arrange for them. They could come and have that done, have it reviewed by the anaesthetist, and providing everything was okay, then they can still come and have their operation.
Patients come into pre-assessment clinic, we're like them to bring a list of all the medicines that they currently take, and that way we can look at any medicines which we may need to stop to avoid any complications in the operation.
Not taking that. Just paracetamol? Yeah. Okay.
We also ask if there's any herbal remedies to take, just so we can take note of them, and anything to buy regularly from the pharmacy, and then we can offer advice on which ones need to be stopped and for how long.
People must try and avoid certain things before coming for surgery, possibly about 3 weeks before, not to do gardening. That's mainly in case they get scratches on the legs, which may introduce infection. And also shaving legs is another thing that can introduce infections as well if they nick themselves, so it's important not to shave the legs within 3 weeks of surgery.
We provide them with octenosan body wash, which is just the same use as shower gel. It's an antimicrobial agent and it reduces bacteria on the skin. We ask patients to wash with this before they come in for their surgery.
Patients come to us on the day of admission, So if you go to theatre in the morning, they will arrive around about 7 o'clock in the morning. If you are going to theatre in the afternoon, it would be about 11 o'clock in the morning. So they've already been pre-assessed, so they know what they're expecting, they're starved, they're prepared for theatre. When they arrive on the ward, they are met by the anaesthetist, the consultant, the nurse practitioner, the nursing staff, the physiotherapists, and we all go through our individual assessments to prepare the patient for theatre. We will assist the patients into an operation gown, and we will warm them pre-operatively. So all patients go underneath an electric blanket, which is called a hot dog, and they will be pre-warmed for approximately an hour and a half before they go to theatre, so that their temperature is at an optimum level, and that's all to reduce the risk of infection.
Mr. Black? Dr. Homan, one of the anaesthetic doctors. Just a quick chat before your operation. I've had a good look at your notes, so I know you've had anaesthetic in the past.
So we'll come and see them first thing in the morning and review their medical history, and from that decide the best anaesthetic for the procedure. The vast majority of patients will have a spinal anaesthetic. This spinal anaesthetic is a process where local anaesthetic is injected into the fluid in the back that surrounds the nerves that supply the legs and the tummy. And that local anaesthetic numbs those nerves, so the legs, the sensation of pain from the legs is gone, and actual strength in the legs is gone, so your legs go numb and heavy. And by doing that, we could quite easily do the whole procedure without anything else extra.
The theatre staff will come to collect the patient and take them round to theatre, and the patients are given a choice whether they're able to walk, whether they go around in a wheelchair, or whether they're pushed around on the bed.
So we started fast track hip replacement here in 2008, and we've now treated about 1,000 patients a year. So we've got quite a lot of experience now of people going through that process. It's something that we've developed and refined along the way, and I think we're quite proud of, and certainly quite a lot of trust around the country come and see how we do it. So the operation itself is completely standard, and the special bit, if you like, is the pre-habilitation, so preparing people for surgery and after surgery. So routinely we would expect people to be up and walking on the day of operation, and then generally they'd be getting away home the day after the operation, or perhaps a day or two later. The process runs very much smoother if patients work with us as opposed to being passive in the treatment. The plan here is an uncemented cup, and put in screws, and then I'm going to be leaving a defect here, which I'll be putting in some shaved off bone into the top, tamping it in, and hopefully getting the cup stable. The theatre, you'll see, has got a special canopy in it which reduces the bacteria by about 30 times. So everything's gone fine?
Right,
are you
okay.
Nice and warm?
Yeah, lovely and warm.
Okay, good. So the plan this afternoon is to get you up,
right,
get you walking about,
yeah,
and hopefully get you away tomorrow or next day.
right, okay, lovely. Thank you very much. Thank you. Everybody's been so lovely.
All right.
Thank you.
The Trust's taken an awful lot of new initiatives forward to improve surgical site infections, and nurses have had additional training. The theatres are cleaned with special cleaning agents in between cases to make sure that there wouldn't be any contamination, equipment sterilised appropriately in between cases.
The anaesthetic will take approximately 2 hours to wear off. Could take longer in some patients. Once the anaesthetic's worn off and they have sensation of their legs and they can move their legs, they can feel their legs, we will aim to get the patient up as soon as possible. So that would either be with the physiotherapist or with the nursing staff, depending on what time of day it is. Now we do audit this because our aim is to get all patients up on day zero being the day that they've had their operation. Our aim is to get them standing so that their feet are touching the floor, they're standing, they're taking a few steps on that day.
Good. Feel the chair with the back of your good leg. Well done. And that's it. That's it.
Most of our patients will always start to get up and mobilise with a Zimmer frame first. This is very stable and easy to use. The sequence to walk with this is walking aid first, then your operated leg, then your unoperated leg. As you progress, we'll show you how to do a step through pattern, so you're putting one foot in front of the other again. When it's obvious that you're ready for this stage, we'll progress either onto crutches or sticks. Generally speaking, patients who've had a knee replacement will use elbow crutches, and those who've had a hip replacement will be able to use sticks, provided we don't need to reduce the amount of weight going through the leg for any reason. Before we contemplate doing a stair assessment, we'll make sure that you are safe with either your crutches or your sticks and you're confident using them. When we go to stairs, there will always be 2 members of staff present for safety, and we'll ask you which side your banister is on at home, where possible, so we can make it as lifelike as we can. Put this one back on.
So what would you put your pain score at now? Probably about 2.
Patients will be asked to score their pain. We use a traditional pain assessment tool, which is to get the patient to verbally rate their pain using a scale of nothing is no pain and 10's the worst pain ever. And we would ask the patient to put a number on their pain, and whatever number they give to the nurse, that will then guide the nurse to decide which analgesia is more suitable for that patient.
Some of the common medicines you'll be started on will be painkillers. If we can relieve as much pain as we can, it'll help you to mobilise more after surgery, it'll help you feel more comfortable. In with that, you may feel nauseous after the operation, so we'll give you some anti-sickness tablets. You may develop constipation, so we can give you laxatives.
The patient will be fit for discharge once all of their assessments are complete. So once the surgeon's happy with the progress, nurse practitioners are happy with their progress, physiotherapists, occupational therapists, and that tends to be around about day 2 to 3. On discharge, obviously the patient will have a wound, so that's the primary concern as to how they're going to manage with that. All patients have waterproof dressings on, which are called Jubilee dressings, which are designed to stay on for 2 weeks. We would advise the patients to keep that dressing intact, not to touch the dressing at all when they go home.
In their packs for their hips and knees, they will have a wound leaflet about the care of their wound after their surgery. Again, if they don't have one of these, they will be given one on discharge from the ward areas. But again, they can contact us and we can send them out a leaflet as well. And there's also the orthopaedic helpline. This has proved to be very successful. It's a phone number that the patients can contact us at the Wansbeck site or the North Tyneside, and we are there to help. So if they have any concerns at all, especially with their wounds, we would rather that they phoned us first rather than the district nurse and the GP.
We will arrange for the district nurse to follow the patient up anyway, because all patients need to go home on anticoagulants, which are tinzaparin injections. So depending on what procedure you have, if you have a knee replacement, you need to have tinzaparin injections for 14 days. If you have a hip replacement, it's for 28 days. Now, we will have encouraged the patient during the time they're in hospital to actually administer these injections themselves. If that's not possible, or if that's something that they don't want to do, we would inquire whether there was a family member or a relative that was able to do that for them.
When the patient's actually discharged from hospital after they've had the surgery, they will go home with the surgical TED stockings, and the patient needs to start thinking about who may help them put these on after surgery, if they've got some family or friends around that can help with that.
We ask all patients on discharge if they can fill in this short questionnaire. It literally takes 2 minutes. It's 6 questions and it's just tick boxes so that we can get patient feedback. And we have had some good results, some fantastic results.
For me, it was an incredibly quick recovery period. The anaesthetic itself, when I came back, I didn't feel like I'd had a big anaesthetic, and I'd had them before for other surgeries. I wasn't sickly, I wasn't sleepy. I came back before lunch, I had my lunch. I was up at 2 o'clock, and I think because I stood on my hip straight away, I had the confidence in it.
During May 2009, the hip and knee fast-track operations team won this trophy at the North East Health and Social Care Awards, and that was followed by other success. This for preventing infection in operating theatres, and this one also for combating infections. Northumbria is committed to improving outcomes from surgery within the Trust and other NHS hospitals. We may contact you about specific trials we are running comparing treatments so we can improve outcomes for people with your condition in the future. It is completely up to you if you wish to take part. Most of these don't involve any additional time spent at appointments. The NHS now funds operations based upon the quality of surgery and how patients feel about the results they have had. We are about to show you a clip about patient-reported outcome measures, shortened to PROMs. This involves you completing a questionnaire about your symptoms before and after surgery. We will contact you separately about this, but if you are able to fill in the questionnaires, it helps secure funding for your local hospital.
I think it's crucial that staff understand what the patient needs are, and you only get that understanding from listening to patients.
Feedback for patient care is very important because negative or positive we can make changes to how their future care is affected.
Patients need a voice because we want to learn from them how we can improve the quality of care that we offer.
Patient-reported outcome measures reflects the effectiveness of care and also the patient experience in relation to that care.
PROMs is the first step, I think, of the NHS attempting to capture real quality of care for patients.
Quality is everything to us, quality of care, and looking at how we can objectively measure that and how we act upon it is critical to us.
I think the PROMs will be really good. I think feedback is always, it's not kind of thing you can just stop and start. I think it needs to be continuity, it needs to be happening all the time.
Once patients know about quality of care, then patients will be able to decide where they're going to go for their treatment. The results of a PROM will be made available for all, and patients will then be able to see from their before their operation status to then their post-operation status how their quality of life has improved.
But we haven't been so good in the past about getting the patient's perspective, the whole experience they get in the hospital. What's their experience been like before they come in, the communication they've had from the hospital, what they're expecting out of their operation, whether actually we've achieved what the operation was trying to achieve. Is their quality of life better? Have you become more mobile? Has your pain reduced? All those sorts of things we haven't systematically recorded in the past.
It's important to know how good we are at treating patients. Although hip and knee replacement, for example, is a very successful operation and makes a massive difference to people's lives, we know that from the look on their faces and what they tell us when they come back. But it's good to be able to quantify that so we can tell what we're doing well and what we're doing badly and which areas of the patient journey we need to improve on so we can provide the best quality of care in the future.
Yeah, and working on what the patients want rather than anything else, because it's feedback from the patients is what it needs.
Definitely worthwhile what you're doing, and to get as much feedback is helpful for the NHS to react, if you like.
At its heart, patient-related outcome measure is about you as a patient, what your experience was like in having your operation rehabilitated.